Good evening, doctors. This is Chitrakla from Shield Connect. Thanks for joining all the doctors in the pleasant evening. Today, we cordially invite you for the webinar on PCOS and infertility, organized by SCALE. SCALE is Sri Chakra Academy of Learning and Education in Infertility. I have immense pleasure to introduce Dr. Vasunthra ma'am. Dr. Vasunthra ma'am is a medical director of Sri Chakra Fertility. Ma'am is an executive committee member of TAPISA. Ma'am's qualification is done her MBBS in Jawaharlal Nehru Medical College, and ma'am is a gold medalist from SRMC and RIDNB from Apollo Hospital. Ma'am trained in ART from NUH Singapore and University of Kiel, Germany. Ma'am have FOXY certified training in fetal medicine and advanced ultrasound from CAMR Edapal. Ma'am is a professor in department at Railway Hospital for DNB for postgraduates and training in reproductive medicine. Ma'am is the founder of SCALE, which is the Sri Chakra Academy of Learning and Education in ART. Ma'am presented numerous number of national and papers in national and international forums. I'm handing over the session to Dr. Vasunthra ma'am.
Thank you, Chitra, for that kind introduction. It's indeed a great pleasure and honor to again meet all of the doctors and delegates who have joined here for yet another webinar organized by SCALE. This webinar is extremely important because September is considered to be PCOS Awareness Month, and today being the last day of 30th of this month, we are just organizing this webinar with a very eminent speaker and a very senior doctor in the field of obs-gynae. I have here, can I have Dr. Nivedita Madam CV, please? So, Dr. Nivedita Bharati is a senior consultant obs-gynae, obstetrician and gynecologist. She's an FRCOG, and many of us know her for many, many years. I think almost close to 3 decades in her practice now. She is the head of the department in obs-gynae in Apollo Hospitals, Vanagaram, Mercury Hospital, and her areas of interest are high-risk obstetrics, gynec endoscopy, and menopausal health. She is an active member in the RCOG, and she's had various papers and publications to her credit. It's indeed a great pleasure to have you here this evening and to talk on a very, very important topic, the adolescent PCOS. I think it is the need of the hour, whether it is lifestyle or whatever it is. I think years together we are discussing PCOS, and I think we will be discussing this for years to come as well. So over to you, Dr. Nivedita Bharati, to take over the management and of adolescent PCOS.
Thank you, Dr. Vasundhara, for the kind words. And I'm extremely happy to be amongst you today evening as part of the PCOS month, Awareness Month. And I'm really happy that you're organizing an educational program like this from your center. And can I start my presentation right away?
Yes, ma'am.
Can I start sharing my screen?
Yes, ma'am.
Can you see my screen?
Not yet, ma'am.
Not yet. 1 second. Can you?
Not
Yes,
yet.
ma'am.
Yes.
Okay. So as we all know, PCOS has become a household name nowadays. So today we have our patients walking into a clinic straight and saying that, ma'am, doctor, I have PCOS. And this is the usual name that they say that they are having. So whether in the adolescent age group, there is a lot of differences between PCOS in an adult female and a PCOS in an adolescent. Because of the various changes in our lifestyle and the increasing prevalence of obesity in our population, because as we all know, obesity has become a pandemic worldwide, be it developing countries or developed countries. So PCOS is something that every doctor, from every specialty see in their day-to-day practice. So what is so special about PCOS in adolescents? So how is it different from an adult female? So as we all know, polycystic ovary is very prevalent in our society and is one of the most common endocrine conditions affecting 8 to 13% of women. And when it comes to adolescent, it is prevalent in about 20% of adolescent girls, depending on the diagnostic criteria used and the population studied. So why is it different from an adult PCO? The physiological changes, including the menstrual irregularities, hyperandrogenism, and PCO morphology, overlap with the adult diagnostic criteria because most of these are physiologically normal events in an adolescent who has just started having their periods. So, making the diagnosis during adolescence challenging and the most controversial one. At the same time, what we have to understand is we shouldn't be overdiagnosing. At the same time, we should not be missing the diagnosis so that the long-term complications can be prevented effectively if we treat them at the correct time. So when you come to the diagnostic criteria, as I told you, there is a lot of difference in the diagnostic criteria between diagnosing a PCOS in an adult and an adolescent. A systematic review evaluating the diagnostic criteria during adolescence demonstrated that all the studies require the menstrual irregularities as a sole criterion to be present for the diagnosis of PCOS in adolescents. And the special criteria should be used. What is a menstrual irregularity in an adolescent? There is a lot of difference between anovulation, the definition of anovulation, the definition of menstrual irregularity in an adolescent and an adult. And most importantly, the primary amenorrhea or the lack of menstruation within 3 years of telarchy is a feature of adolescent PCOS within the criteria of menstrual cycle irregularities. So what all these academy and the society say about the diagnostic criteria of menstrual irregularities. The American Academy of Pediatrics and the ACOG published criteria to define menstrual abnormalities for adolescents. What they say is the presence of persistent menstrual cycles longer than 45 days of duration during the first 6 years following menarche should be considered as oligomenorrhea, which is different from the adult definition. So when we look at various definitions of the menstrual irregularities in an adolescent, there are various criteria. They are defining the menstrual criteria according to the years post-menarche. If it is within the first year post-menarche, there is no different criteria. That is, then when it comes to the second to third year post-menarche, there is a definite thing that we have to remember. That is, irregular cycles are normal in the first year post-menarche. When it comes to the first to 3 years post-menarche, the menstrual cycles anything less than 21 or anything more than 45 days should be considered as a menstrual abnormality. And menstrual cycles less than 21 to 35 days, 3 years after the third year of menarche, this should be considered as abnormal. And in the first year post-menarche, even though irregular cycles are common, that is what we are taught, anything more than 90 days of duration should be considered abnormal. So that all these criteria should be considered when we say that a particular girl is having menstrual irregularity. As I told you earlier, it is the primary amenorrhea by 15 years or lack of menstruation after 3 years post-telarchy should be considered as abnormality, and it should be included in the menstrual irregularity definition for adolescents. And the next important criteria is the hyperandrogenism. So it can be a clinical and the biochemical evidence of hyperandrogenism. This is defined as by the modified Ferriman-Gallwey score 4 to 6 and or severe acne and rarely alopecia. So biochemical in the females with irregular cycles, yet without hyperandrogenism, testosterone, free testosterone or free androgen axis can assist with the diagnosis, even though there are no cutoffs given for the adolescent age group in particular. So this is what we have to keep it in mind. When we say menstrual irregularity, if it is in the first year post-menarche, anything more than 90 days, if in the first 3 years, 21 to 45 days out of range, and if it is post 3 years, it is less than 21 and more than 35 days, and primary amenorrhea by 15 and 3 years post-menarche, all these should be considered as the menstrual irregularity in an adolescent. So anovulation, it is another aspect that differs in adolescent girl compared to adult women. However, studies evaluating ovulation in the years following puberty have shown ovulation in only 20% and in 25 to 30% in the second year post-menarche, and gradually increases to 70% in the years of 5 to 9 years post-menarche. Another noteworthy difference between adolescent girls and adult women is that oligomenorrhea has been used as an index of presence of anovulation in the adult, whereas in an adolescent, it is not so. In adolescent, menstrual cycle irregularities do not necessarily indicate the presence of anovulation, and a large proportion of healthy adolescents with irregular menstrual cycles will be still ovulating despite irregular and infrequent menses. So this is a very nutshell of what I have been telling you so far. Isolated menstrual irregularities, but no hyperandrogenism. When there is hyperandrogenism but no menstrual irregularities, hyperandrogenism and menstrual irregularities in the first year, and hyperandrogenism and menstrual irregularities 1 to 3 years, and the features of metabolic syndrome and menstrual irregularities. When the adolescent girl fits into any of these categories, she has to be assigned as having at risk of PCOS, and follow-up and a healthy lifestyle should be recommended. This is how an adolescent PCO differs from an adult woman. And as I told you, hyperandrogenism is maybe clinical or biochemical evidence of hyperandrogenism, and the hirsutism and acne are considered to be the physical manifestations. And mild to moderate acne is a common among adolescents and among adolescents with PCOS as well. So, however, when acne is more severe, PCOS should be considered to be a diagnosis. But there is no consensus on a single score for evaluation of the severity of acne, as we have to assess the severity of hirsutism. Another feature of clinical hyperandrogenism is the female pattern hair loss, or previously called alopecia. This is a diffuse thinning of the scalp hair around the crown area that can be present in about 1/3 of the women with PCOS. There are no studies specifically evaluating the female pattern hair loss in adolescents, and the two studies from the Middle East, which found that it is a very, very less percentage of girls, adolescent girls, with a female pattern hair loss, which is about less than 2%. So these are all the various tests that we do use to assess the biochemical evidence of hyperandrogenism. So that is the free testosterone, free androgen index, and the bioavailable testosterone as a measure of biochemical hyperandrogenism. So what do we use? Whether we use the free testosterone or the free androgen index. What is free androgen index? The free androgen index is the ratio of the total testosterone to the sex hormone binding globulin. When we suspect a decrease in the sex hormone binding globulin, which can be present in the PCO, it is always better to use a free testosterone. Adolescents with a free androgen index are more likely to develop PCOS at the age of 26 years. And adolescents with isolated hyperandrogenism, that is the clinical or the biochemical features and regular menstrual cycles, should not be diagnosed as having PCOS, but should be considered at risk of PCOS. Apart from all these blood tests, as I told you, the menstrual irregularities and hyperandrogenism are the two important features that has to be present to diagnose an adolescent as having PCO. There are other blood tests that we need to do to rule out the other possible common causes for the clinical symptoms of PCOS. So which include the beta HCG. If the adolescent is sexually active, the first thing is anybody in sexually active sexually active, the first thing is to rule out the possibility of the pregnancy. And the LH and FSH. FSH is usually used to diagnose or to rule out the primary ovarian insufficiency in an adolescent with history of amenorrhea, thyroid function test, and prolactin, and 17-hydroxyprogesterone, which is very common, that help us to distinguish from PCOS from the non-classical congenital adrenal hyperplasia. And androstenedione can also be elevated in the non-classical congenital adrenal hyperplasia, and it is also mildly elevated in adolescents with PCOS. But the very high DHEAS levels are more likely to indicate the presence of androgen-secreting tumor. So the most important message I would like to say is pelvic ultrasound to evaluate the PCO morphology. Even though pelvic ultrasound and PCOM are part of the Rotterdam diagnostic criteria for PCOS in adult women, it is not recommended for the diagnosis of PCOS during adolescence, as it can cause overdiagnosis of PCOS during this stage. The second reason for avoiding using a pelvic ultrasound, including adolescents, which can be a transient condition. And pelvic ultrasound can be used, on the other hand, to rule out other possible abnormalities in adolescents that present with primary amenorrhea. And AMH levels are very much discussed as part of the diagnostic criteria or the diagnostic tool for PCO, but it has not been validated in all the studies. So this is again a nutshell of what I have been talking to you so far. First year post-menarche, second year post-menarche, what are all the things you have to look for with regard to menstrual irregularities? And if it is more than 3 years, then it has to be like this with hyperandrogenism, either clinical or biochemical. So once we are sure now about the diagnostic criteria of PCOS, how to approach a woman or a girl who comes to us with menstrual irregularities and features of hyperandrogenism. So the clinical assessment starts with the history, as we all know, and the physical examination, which includes assessment of present illness focused on the patient's clinical symptoms, medical history, reproductive health history, menstrual, social, and contraceptive use if the adolescent is sexually active. And the presence of symptoms that are consistent with PCOS, that is weight, hair, or skin changes, assessing for other disorders that may impact the menstrual function like thyroid enlargement, that is hypothyroidism, headaches, which may be a part of galactorrhea amenorrhea syndrome, galactorrhea, weight changes, skin and or nail changes. So to put it in a nutshell, a comprehensive physical examination can be done that includes the vital signs, anthropometric assessment for assessing the BMI, general appearance, skin survey to detect alopecia, male pattern baldness, acanthosis, acne, hirsutism, Tanner staging for breast development in case of primary amenorrhea, examination of external genitalia to assess for virilization to rule out the possibility of congenital adrenal hyperplasia. And the goals for laboratory assessment to support the diagnosis of PCO, to exclude the other causes of menstrual irregularity, clinical hyperandrogenism, assess for associated clinical issues such as diabetes and hyperlipidemia. So these are all the tests that we normally do, and we all know why we are doing all this. Free or total testosterone, DHEAS are routinely measured to assess the contribution of the ovarian and adrenal androgens and consider the possibility of an adrenal or ovarian tumor. If there is hyperandrogenism, if we need to know the source of the androgen, whether it is ovarian or adrenal, we use these parameters to make out the diagnosis. And 17-hydroxyprogesterone should be done in case if we suspect late onset congenital adrenal hyperplasia. Serum FSH should be measured to ensure that the ovary is functioning to assess the ovarian sufficiency. And the time-tested and the test that we have been doing and we have been taught when we were in medical school, that is the LH to FSH ratio, cannot be used to make the diagnosis in isolation. Many patients with this disorder will not have, with this disorder meaning with PCO, will not have elevations of the ratio, and the elevated ratio can be seen in both patients with PCOS and those who are ovulating. So this test is not being used nowadays as the diagnostic criteria for PCO, be it adolescent or adult. They also should be screened for thyroid disease. This is what I've told already. And the metabolic abnormalities, that is type 2 diabetes and hyperlipidemia, should be ruled out. And significantly obese with profound chemical, biochemical, metabolic abnormalities may also present with non-alcoholic fatty liver disease. See, gone are those days when we say fatty liver, nothing to worry, because now it is being identified as one of the risk factors for complications later on. So therefore, the liver function testing is warranted in this subgroup. This is the same thing again, to reiterate that pelvic PCO morphology should not be used in adolescent to diagnose PCOS. Although ultrasound findings have been shown to be supportive of the diagnosis of women, these findings are not specific to the disorder, and the diagnosis can be often made without an ultrasound. So we have the diagnostic criteria defined. We know what are all the tests to be done. We know how to examine the patient and to rule out the other possibilities. Now we land up in the treatment. Because PCOS in adolescents can have lifelong implications for metabolic and reproductive health. So early treatment is critical, and the goals of therapy should be discussed in detail with the patient as well as the parents. Decreasing the risk of endometrial cancer, the goals should be managing irregular periods, reducing hirsutism and acne, decreasing the risk of development of type 2 diabetes, cardiovascular diseases, thereby improving the quality of life, and most important, preserving the fertility. So the first and foremost is the lifestyle modification, such as dietary changes, exercise, and weight loss, or the first line interventions for adolescents with PCOS. Even though this is the first line intervention for PCO, even in adult women, for PCOS in adolescents, this should be the first, and the most of the time, if it is followed religiously, it may be the only intervention that that girl will require. This non-pharmacological therapy is the critical first step for patients who are overweight or obese, which exacerbates the PCOS phenotype. Weight loss as a sole maneuver can decrease the androgen production, improving sensitivity, insulin sensitivity, and reduces the cardiovascular risk. This is what an adolescent will come to us for, because the hyperandrogenism and menstrual irregularity are the two most common symptoms the adolescent will land up in the clinic. So weight loss as a sole maneuver, if it is achieved, then it will give us most of the results. So when next line of treatment comes the estrogen and progestogen, anti-androgens, and spironolactone, and the other options include cyproterone acetate, flutamide, and finasteride. All these, are towards the correction of hyperandrogenism, that is the treatment of hirsutism and acne. The systemic therapy can be augmented by topical and mechanical treatments for hirsutism, like electrolysis, laser therapy, plucking, waxing, shaving, and bleaching. Eflornithine hydrochloride cream that has been in the market for some time is another option to lessen the facial hirsutism and can augment the side effects of the laser therapy, but at its own side effects, which causes folliculitis and burns locally. So for acne, topical retinoic acid and antibiotics can be helpful adjuncts to oral antibiotics, hormonal therapy, and anti-androgens. Adolescents with PCOS, as I told you earlier, often seek care regarding their irregular menses, infertility, hirsutism, and acne. The propensity of obesity and cosmetic concerns may lead to poor self-esteem and depression. So do we have a role of vitamins and supplements in the treatment of adolescent with PCOS? Is there a role of vitamin D? As we all know, I think vitamin D is linked to anything and everything, because almost 80 to 90% of the population in our country and most of the countries are deficient in vitamin D. Whether probiotics has a role, and omega-3 fatty acids, whether they have a role in the treatment of PCO in adolescent especially. We don't have any conclusive evidence, but all these things can help to bring down the inflammatory, pro-inflammatory conditions of obesity. But this alone will not help unless the patient works for her weight loss. In a recent review, the cardiovascular profile of the pharmacological agents that have been used in the management of PCOS was reviewed. So what are all the agents? Which include COC, which is commonly used, anti-androgens, clomiphene, and drugs specifically used in diabetes therapy, including the metformin. So the cardiovascular profile of these agents have been reviewed, and what they found in this review is the therapies used to treat these patients do not confer an increased cardiovascular risk. That is good. But there is no evidence that any of these interventions may prevent the onset of diabetes in patients with PCOS. But what they have found out is metformin was suggested to be beneficial in preventing the development of gestational diabetes. And the other drug called orlistat is a noteworthy medication that reduces weight that is being given for weight loss and therefore might lead to decreased cardiovascular risk. But in a recent systematic review, it has been suggested it is more effective in improving ovulation rate, weight loss, and lipid profiles in women with PCOS, which I think the next speaker will clarify for us whether it is useful in the infertility in PCOS women. Lastly, a 2018 study revealed that orlistat is more effective and has fewer side effects than metformin, which is still has to be proved in larger trials. And to conclude, the PCOS diagnosis during adolescence is more challenging and controversial due to the overlap with physiological events of puberty. The only criterion that applies to adolescents from all adult diagnostic criteria is the exclusion of other conditions that mimic PCOS. And the two main criteria are the menstrual irregularity and the hyperandrogenism. And pelvic ultrasound should not be used as a criteria to diagnose adolescent PCOS. The research, including adolescents who meet only one of the PCOS diagnostic criteria, either they will be having only hyperandrogenism or only menstrual irregularity, is limited as present. But these adolescents should be considered as at risk of PCOS, and follow-up should be established with reinforcement of healthy lifestyle to prevent the long-term complications. PCOS, as we all know, is a common diagnosis, but it is far from one-size-fits-all with respect to treatment. Optimal treatment uses a multimodal approach, including nutrition and exercise interventions in adolescents. That should be the first and foremost treatment options in adolescents. Long-term individualized management that integrates evidence-based practice using a combination of pharmacological interventions, topical treatments, lifestyle intervention, and social support for patients with PCOS is needed. Attention to both the physical and emotional health, which is often not recognized, is paramount as part of the personalized management strategy. Thank you for your time, and I'm happy to take any questions if there is.
Thank you so much, Dr. Nivedita. That was a wonderful talk on adolescent PCOS. It is a vast subject, and you have concised the whole thing for us to understand the basics of the history taking and then how to really diagnose adolescent PCOS, because many of our mothers would approach you in the OPD, immediately after their menses. Within a year, they're worried. And nowadays, the knowledge about PCOS is so much, as you rightly said, they come with a diagnosis of PCOS, and how to really diagnose in an adolescent age is a definite controversy and a dilemma. Thank you for throwing a lot of insight into it, and also thank you for laying the foundation for my next talk, because lifestyle again is a very important factor in PCOS, and volumes of books have been written, and so much of awareness of lifestyle factors have been created across decades now. And without lifestyle modification, none of our medications are really going to work. Another very important point which you put across to all of us is PCOS is a multidisciplinary approach, and definitely, it requires the intervention of the dermatologists for their cosmetic problems, the endocrinologists, the gynecologists, the family physicians are the leading you know, uh, uh, there is no need for the psyche of the patient. Interventions in the management of adolescent PCOS. Wonderful talk, and thank you for taking everything about adolescent PCOS in half an hour time. So, can we do the Q&A at the end of the session, or if you want us to, are there questions now in the chat box? I finish my next talk, then we do that. Chitra?
Ma'am?
Hello, am I audible?
Yes, ma'am.
Okay. Can I share my screen and start my talk? Hello?
Ma'am, ma'am, உங்க வீடியோ வேணா கட் பண்ணிக்கோங்க மேம்.
Okay. Can I share my screen, Chitra?
Yes, ma'am.
Is it visible?
No, ma'am.
Hello?
Yes, ma'am.
Is my
No, ma'am. Ma'am, your network is very poor.
I
Bandwidth is
think
very
your
poor.
video is also very shaky, Vasundhara.
Is the screen visible now?
Yeah. Yes.
Yes, ma'am.
Yeah. So sorry, there's some network issue. I'm just starting without. Right. So in the next few minutes, I will do lifestyle factors overall and its impact on fertility, because it is very important. Though PCOS will be part of the lifestyle factors that's going to
Your voice
cause
is
a
not
lot of
clear.
issues among women. My voice is not clear.
I mean, it's getting interrupted in between.
Okay, okay. So sorry about that. There is some technical issue which we're trying to sort out. A minute, please.
Ma'am, Basantara ma'am.
Voice is better now?
Yeah. Yeah. Yeah.
Yeah, okay. Yeah? Oh, okay. Wow. So I'm going to overall discuss about lifestyle factors and its impact on fertility, and more so in the end, I would be dealing with how lifestyle factors can create a havoc in women who is contemplating to, begin her family and have a parenthood established. Uh, it's very important because at adolescent level, this PCOS has a lot of impact when this woman goes through, reproductive age group. So we need to address this PCOS at the very young age so that they don't land up in major issues. So lifestyle factors are extremely important, and especially so when it's going to have an impact on her fertility. So slide change on that. So lifestyle includes the behavior and activities that make up your daily life. It is the work you do, your leisure activities, the food you eat, and the way you interact with family, friends, neighbors, co-workers, and a lot of other things. So it is the way of life, and it can relate to mental and or physical health conditions such as various disorders, obesity, asthma, sexually transmitted diseases, depression, and anxiety. Is fertility a modern issue? Definitely not. But however, as the era progresses in 1970s, we all know that the woman was getting married in the age of 20s. So 20 to 28 or to 30 years, the reproductive potential is at the peak, and there was never a major issue of fertility a few decades ago. But over the years, this trend is changing, wherein the woman is getting married advanced maternal age above 30, 35, and their fertility potential is definitely coming down because of various reasons. This has changed because of various reasons, because of their career choices, and because of various other reasons. Women are getting married at a very later age. So what do we know? 1 in 6 couples have fertility challenges, and lifestyle choices definitely may contribute to infertility, and social trends lead to different childbearing age and care, and most patients are not aware on their potential consequences, and there is no evidence-based guidelines available for this aspect, and we need to have more and more focus on lifestyle modification and counseling. So infertility factors cannot be identified 100% in all the couples. It's identified mostly in 70 to 80%. And, different results are obtained of treatments in patients with the same causes. So you don't expect the same outcomes despite every woman. For example, a woman has 10 people have PCOS, they might be having different outcomes of the same condition. There are a lot of adjuvant medications, and patients underestimate the influence of certain factors. Like, when we give adequate counseling in our OPD, they need to be understanding what is the serious impact of lifestyle modification and their fitness level, how their stress levels to be reduced. All these, are underestimated many times. There are certain modifiable factors and non-modifiable factors, and with appropriate counseling, we may be able to improve natural fertility, improve reproductive treatment outcomes, and reduce obstetrics and neonatal complications. The main factors which are implicated here is differing childbirth and aging, differing treatment, associated problems like smoking, alcohol abuse, increased caffeine intake, environmental toxins, obesity, and psychological stress. We are all aware. Why are we talking about age, and age? This is because advanced maternal age has got increased risk of miscarriages. As a woman advances in age, if you just have a look at 35 and above, the abortion rate is 18%, and above 40 to 45, the abortion rates is 70 to 80%. And all of us know this is because of the aging oocytes leading to aneuploidy in the oocytes and leading to aneuploidy and miscarriages. Also, most important is, as the woman advances in age, the fertility potential also decreases, and she is unable to conceive. And also, the maternal age is an important indicator for having a baby with Down syndrome. So these are all very, very important, and success rate in an ART treatment also starts decreasing after the age of 35. So if you look at her own potential of conceiving with her own eggs starts decreasing after the age of 35, and when the woman crosses 40, there is an exponential decrease to the tune of less than 5% when the woman is more than 45 years. So the conception with donor gametes goes up as the woman advances in age. So these are all very, very important for us to understand and counsel our patients so that they are aware of the fertility potential and also their biological clock, so that they are aware to approach the fertility specialist to start their treatment as early as possible to avoid miscarriage risk and achieving their pregnancy as early as possible. Now, there are a lot of barriers in conception, and there is a lack of understanding, and always we think it is only the female, and also we need to consider the male partner as well. And there is a lot of research about advanced paternal age as well. So we think that, men are fertile even at 50, 60, their semen quality is good, but we are also we have to look at the progeny, the child which is being born, wherein the man is of advanced paternal age, especially more than 40. There is a lot of things about psychosocial development and also autism spectrum disorders in the offspring that is born out of a male who is more than 40 years of age. So we need to have an awareness about that as well. So lifestyle modification should be behavioral, material, and psychological. Behavioral in the form of diet, smoking, consumption of alcohol, drug addiction, lack of physical activity are all behavioral things which leads to problems which needs to be addressed. Environmental toxins and stress. So diet and lifestyle should be, this fertility is achieved by maintaining a careful orchestration of complex processes that can be disrupted by a number of factors related to body weight and dietary intake. All of us talk about balanced diet. The importance is tremendous. So definitely a balanced diet which includes fruits, vegetables, and moderation of your proteins and carbohydrates and fats, what to avoid and what to consume in moderation, and what is liberally allowed is to be, our daily way and daily practice. So older generations, they consumed healthy foods when they compared to what people consume today. Diet of people has changed a lot from natural ingredients to artificial ingredients. And in our people, in our families, if you look at it, we mostly consumed food which was cultivated in their own farms. But now this is not the scenario. The quality of the seeds, the vegetables are all adulterated because of pesticides or preservatives for keeping them for longer duration and using. So it's always better for us to consume locally available seasonal foods rather than those foods which are have to be imported from various other countries, wherein they have to be using preservatives for their long-term use and use for consuming. So these diets definitely have more sugar in them, consumption of soda, fruit juices, the calories are high, and people are eating more of processed foods, and egg consumption, especially the egg whites, it's very low, and uses of processed foods and oils also is going to be taken very liberally these days, because it is easier for us to get these foods, and especially with all these online platforms which is like Swiggy and Zomato, which is available, and we are forced to at times you choose the easier option to select these kinds of foods, and then we get into a lot of problems in our day-to-day life. So junk food, we are all aware about the junk foods, because that leads to both short and long-term effects like lack of energy, can lead to poor concentration, high cholesterol, and heart diseases. So we all know we have to avoid junk foods, but we have to keep reinforcing the same thing again and again in the younger generation so that they are living a healthy life. So definitely a healthy diet. The keys to have a healthy diet is to have variety of nutrient-rich food, enjoy plenty of whole grain foods, fruits, vegetables, maintain a healthy weight, eat moderate portions, eat regular meals, don't eliminate certain foods, and balance your food choices over time. So never go on a crash diet, never follow something like a keto diet, never follow something like, which is a shortcut and which you feel that that's going to be a game changer in losing your weight. So it's always a balance between choosing a healthy, balanced diet, exercise, which is going to give you a better, consistent result so that we can maintain a healthy lifestyle. Obesity is definitely a pandemic now, because many of our children are, especially post-COVID times, they have resorted to online platforms for many classes or many programs, and they lack physical activity outside. And this is going to be a cause of future problems, and diabetes, hypertension, gallbladder disease, liver disease, cancer, coronary artery disease, cerebrovascular diseases, endocrine changes, obstructive sleep apnea, psychological function, osteoarthritis, and various other related problems. There is numerous literature on related to obesity, menstrual irregularity, ovulatory dysfunction that it produces, decrease in the ovulation, and also pregnancy rates. Obesity can be associated with decreased success rate following IVF treatments, especially when they're going for an IVF program. We need to use more dosage of gonadotrophins for response. And then the risk of miscarriages, especially in overweight women, the risk of preeclampsia, gestational diabetes, thromboembolic diseases in these women are all, studied over many years. So nutrition-related disruptions in fertility, it can be because of undernutrition, weight loss, obesity, high exercise levels, specific diets, as I mentioned, like fat diets, specific food components, fat, fiber, soy, and carotene. So effects of weight loss, as simple as 10 to 15% of body weight loss can decrease the estrogen and testosterone levels. And when they lose even a 6 to 7% of their weight, their fertility potential is naturally enhanced, and we should all focus on consistent weight loss. So if a woman or a man is morbidly obese, suddenly to reduce their weight to 20 to 30 kg is not possible. At least we need to concentrate on 7 to 8% of weight loss so that they are able to get into a proper shape for fertility treatment and also a better outcome. So definitely it is associated with irregular menses, PCOS, and fertility issues. So 12% of all infertility cases are associated with women who weigh either too little or too much. So when we look at the male factor, if you see over the years, the male factor infertility is raising, and also there is decline in the sperm quality. It can be because of environmental factors, lifestyle factors, or dietary factors, and especially with the usage of cell phones. There's numerous studies which have studied on the semen quality parameters, on the number of hours a man uses the cell phone, especially placing the cell phone in the trouser pockets. And they have studied that less than 2 hours, 2 to 4 hours use and more than 4 hours use, and everything has implicated in poor semen parameters in men who have used cell phones. It has affected the quality, both the sperm motility, vitality, and morphology. So we need to, use these technology in moderation, and it is extremely important. So potential contributing factors are many, but we need to focus on lifestyle. So excessive heat, their occupational hazards, heavy metal toxicity, cigarette smoking, pesticide exposure, and again, their food habits and sleep patterns. So the various nutrients that are important in maintaining the sperm health, especially, if the fertility is important, the motility, the acrosome reaction. So we have various nutrients playing at various levels for appropriate fertilization and pregnancy chances. So adequate intake of essential fatty acids are extremely important, like carnitine, arginine. So you have a various antioxidant medication which give us a holistic way to address the sperm parameters. However, we should also know those foods which can be taken naturally other than the medications. For example, the vitamin E is very much available in whole grains, broccoli, nuts, wheat germs, and leafy vegetables. Vitamin A, we have good sources in cruciferous vegetables like broccoli, sprouts, cabbage, and cauliflower. Vitamin C, again, in citrus fruits and cruciferous vegetables. And if you look at iron, zinc, we have whole lots of wheat germs, seeds, leafy vegetables, and essential fatty acids in safflower and other vegetable oils. The most important thing is when we when it is taken in food forms, vitamin and minerals are best absorbed and utilized by your body rather than in the pill or supplemental forms. So we need to be aware of choosing the best food which is going to give us all these balanced food which is going to improve the sperm health. And what to avoid is very, very important. Food related items, definitely alcohol, artificial sweeteners, food coloring agents, your excessive intake of caffeine, and many of our products which we go to the supermarket and choose, we need to see the ingredients. Though they say no sugar, it is your monosodium glutamate, they'll be mentioning it as MSG, BHC. These are all food additives which are very, very harmful, and we should be avoiding certain products so that we choose healthy foods when we go and pick foods from the supermarkets. So other than this, there are a lot of other medications that can reduce the fertility potential. Smoking is definitely a no and a harmful impact both in male and women. In women, there is a lot of rise in smoking and drug abuse, which is going to cause a lot of issues in terms of increased risk in ectopic pregnancy, miscarriages, IUGRs. Relative risk of infertility is increased by 60%. When they go for fertility treatment, there is a very, very high dosage of gonadotropins that is required in women who smoke. So we need to create more and more awareness and ask for history of smoking, because nowadays it is quite common even in the women. So we need to address this. And smoking also is very, very detrimental to the sperm, and the damage is almost always permanent. We can only kind of prevent further damage, and we need to counsel the man that it is one of the important factors that is going to cause the DNA fragmentation in the sperms, and that is an important reason for miscarriages and poor fertility treatment outcomes. So again, alcohol, though many of us say that, literature used to say that, mild alcohol consumption is okay, but there are lots of papers now coming up. Even a mild or moderate consumption of alcohol is a high risk for future cancer development and other health related issues or liver disorders. High levels of caffeine consumption definitely decreases fertility, especially more than 5 cups per day, and also has got an increased risk of miscarriage. If you look at next to obesity, overweight women, if you have more than 2 to 5-fold increase in fertility problems, again 5-fold increase in miscarriage rates and decreased success in fertility treatment. 42% of men and 52% of women surveyed with fertility problems said that they were overweight. So this is all purely due to sedentary lifestyle, and sedentary lifestyle is probably, due to the advent of lot of gadgets and technologies and more use of our automobiles, rather than we are not walking to our workplaces, or we are not doing any healthy lifestyle practices. And also we need to sit for long number of hours, probably 6 to 8 hours a day. It has been studied, and various studies have revealed that sitting in a place for more than 6 hours is equivalent to smoking more than one pack of cigarettes. So it's increased likelihood of developing type 2 diabetes and hypercholesterolemia. So how do we modify it? Just simple steps that we can do in our workplace is to stand up every 20 minutes, even if it is for a minute or so. Stand whenever you are in a small meeting, and do simple stretches and exercises at your desk. Head to the recreation center for a quick game or a workout. And if you have a gym or a walking place in your workplace, please take a break and go ahead and do some cardiovascular exercises in between your work time. So physical activity is definitely the need of the hour. It helps you lose weight, feels more energetic, reduces your stress level, lowers the risk of osteoporosis, and it improves your treatment outcomes. Environmental toxins, it is not preventable, though we say plastic free. The bisphenols and the endocrine disruptors are the major reasons that is causing a lot of fertility problems both in men and women, and is also one of the important reasons for miscarriages. So we need to choose our products wisely, be it our cookware, or be it your storage containers, whatever it is. I think we need to choose all these quite wisely. And also the cosmetics which the children use and which the adults use also contains a lot of endocrine disruptors. So it is better always to counsel all our adolescents and the women of reproductive age group to choose these things very wisely. The most common reason for discontinuation of any fertility treatment is because of psychological stress. And one of the commonest reasons which we find is because of their low self-esteem, because of obesity and lack of proper counseling services. So when we talk to them about what is it that is stressing them and give them adequate counseling, how to divert their stress, how to reduce their stress, and what is it that is the diagnosis and what is their realistic expectations out of the treatment, they will be able to embark on fertility treatment without much of a stress. And how to handle this needs to be professionally counseled to them. So if we look at now, I'm going to take us through the lifestyle modification in PCOS. Why is it important? And also there's a lot of things which is coming up in terms of why we need to counsel women with PCOS. So Dr. Nivedita has spoken about length about adolescent PCOS, and it is definitely a complex hormonal disturbance that affects the entire body. And PCOS is already determined in utero as early as the pregnant mother having a female fetus. It is already programmed in utero. So there are various factors, genetic factors, environmental factors, hormonal factors that play in the evolution of PCOS, and it has got numerous implications in general health and well-being, and it can affect all females from adolescence to postmenopause. Now, they described a group of women who are obese and infertile with enlarged cystic ovaries, Stein-Leventhal syndrome, in 1935. And it is one of the most common hormonal abnormality that we see in our day-to-day practice. And it is the first cause for anovulatory infertility. 80% of the women show PCOS morphology or PCOS on ultrasound. 40 to 80% have a fertility issue. 60 to 80% have hirsutism, and a similar number have alopecia. Irregular menses is seen in 70 to 90%, and 40 to 60% have associated acne and hyperlipidemia, and 10% have acanthosis nigricans. Health-related risks that may be associated with PCOS is again insulin resistance, metabolic syndrome, increased risk of diabetes, pre-diabetes, and obesity, and that is what we are all worried about. PCOS women have slightly higher risk of endometrial cancer, sleep apnea, hypertension, mood disorders, heart disease, inflammation, and pregnancy complications. So obesity is definitely linked to mood disorders as well as to abnormal hormone levels, and studies show that the risk of mood disorders is even greater among women with PCOS who are also obese. Inflammation is a process wherein now they are studying the use of probiotics like lactoferrin and other things to reduce their systemic inflammatory response that results from obesity and metabolic dysfunction, or whether it is an independent symptom in the whole spectrum. So PCOS and pregnancy complications, it is advocated as a cause for spontaneous miscarriages, especially in women who are high BMI and PCOS, impaired glucose tolerance, gestational diabetes, hypertension, and small for gestational age. So it can be genetic. It's a environmental component is also involved in it. So I'm not going through a lot about all the causes and etiology. Definitely insulin resistance is increases with age, and it is aggravated by obesity, and it is exacerbated at puberty and in pregnancy. So also can lead to increased food cravings, weight gain, and or difficulty in losing weight. Diagnosing insulin resistance is definitely tricky. It can vary throughout the day, and glucose challenge test is done. Fasting insulin levels are also done, and oral glucose tolerance test is another test, and other predictors like your acanthosis nigricans and waist hip ratio and other things. So we have this group of categories like lean PCOS and obese PCOS. Lean PCOS also have insulin resistance, and it is hypothesized that lean PCOS patients could be affected by an intrinsic form of insulin resistance, whereas obese PCO patients have a combined form of insulin resistance due in part to the syndrome itself and in part to the weight excess. In fact, the lean PCOS patients could be considered to be a unique model to study the natural history of insulin resistance per se, because the insulin resistance occurs in the presence of normal glucose. So obese women with PCOS have a greater insulin resistance than weight match control subjects or lean PCOS patients. So diagnosing, again, the goals of treatments should be focused on regularization of cycle, promote weight loss, correction of metabolic syndrome, decrease the level of androgens, improve fertility, and improve overall well-being. So we need to focus first on lifestyle modification, definitely, that can lower all these parameters and reduce their insulin resistance. Sometimes they can achieve a spontaneous ovulation, and their natural pregnancy chances are definitely higher. Effects of metformin on fertility, metformin is widely studied and a safer form of drug which can be considered throughout the pregnancy in case they develop glucose intolerance or gestational diabetes is considered extremely safe. It has been shown to restore regular menstruation in women more than 90% of amenorrheic adolescents. Restoring ovulation in more than 80% is more effective at restoring ovulation when it is combined with other drugs, when we are giving to stimulate them for ovulation induction as a first line of treatment. And it is quite safe during the first trimester. It also reduces the miscarriage rates. So there is a first step in the treatment is diet and exercise. Benefits include increased regularity of menses, reduces the androgen levels, improves in the lipid parameters levels, and also it can cause spontaneous ovulation and natural pregnancy. We need to counsel exercise, nutrition, and certain practical tips. We need to give them aerobic training, or in terms of resistance training, slowly increase their level of training gradually. This can improve their insulin sensitivity and reduces their metabolic syndrome. So aerobic exercises increases the insulin sensitivity from 20 to 50% amongst all age groups, gender, and body weights. Resistant training is definitely studied in various studies, and it is found to improve their glycemic control and improve their insulin sensitivity. However, this review showed that resistance training, compliance, and glycemic control are generally less without supervision. So a supervised training is highly recommended. High intensity interval training is again going to improve the insulin resistance, but we need to give them a supervised treatment, otherwise the compliance is going to be lost. So benefits of exercise has to be reinforced again and again. It improves the insulin sensitivity, decreases the blood sugar levels, improves the metabolic syndrome, increases the lean mass, and aids in stress management, lowers in the fasting glucose levels. So the recommendation for exercise is anything is better than nothing. Get a baseline and increase levels from there. Ideally 3 aerobic and 2 weight training sessions a week, but not many can do this. Suggest some high intensity training sessions in motivated fit individuals. Increase everyday movement. Consider an activity tracker, and beware of over exercising because it's not going to be compliant. So do not, for patients who are having PCOS, please do not defer childbearing, do not defer fertility treatment, do not defer IVF treatment for women who are above 35. How relevant is this is a choice, because percentage of infertile women when we look at the age factor is the single most determinant, because after 35, both your abortion risk is going to go up and also the treatment success is going to go down, and you have to opt for donor gametes rather than self gametes. So definitely we need to quit smoking, avoid passive smoking as far as possible, lose weight. Delaying treatment to allow loss of weight is definitely prudent, but it has to be considered amongst the background of age as well. So stopping alcohol and consuming drugs and reducing the caffeine intake, how to reduce the stress, add some psychological therapy during fertility visits, refer to professional counseling wherever appropriate, avoid persisting too long with low chance treatment, and move quicker to IVF treatment if woman is more than 35 years of age or older. So to conclude, apparently the lifestyle factors that has the most detrimental effect on fertility potential seems to be the social trend of having a career before a family. We need to make people aware of the consequences, and they could deal with both the goals in a much more efficient way. Fertility is a couple's issue and not a woman's issue. We should be able to slow down this trend if we could create more awareness about lifestyle changes which can impact fertility. Thank you so much for a patient hearing. Chitra?
Yes, ma'am.
If we have any questions in the chat box, we could take those questions.
Yes, ma'am. We have one question, ma'am.
Yes.
Topical treatment for acne in PCOS.
See, the best treatment for topical treatment for acne is that is topical retinoids and topical antibiotics. But it is always better to reach, this is one of the features of hyperandrogenism. So as we discussed, the management of PCOS, lifestyle modifications comes here again as the first option. Next comes the topical application. And if we need more than this, it is always better to consult a dermatologist as well for the more advanced treatments.
Ma'am, there are no more questions, ma'am.
Okay. Thank you so much, Dr. Nivedita, for accepting the invitation and delivering a beautiful talk today on management of adolescent PCOS. It was a pleasure having you on this meeting. Thank you.
Thank you so much again for the opportunity, because I also learned a lot.
PCOD is ever evolving, and adolescent PCOS is a great challenge I'm sure you must be facing in your day-to-day practice. Thank you so much, Shield Healthcare, Mr. Balaji, and also Chitrakala for hosting this platform and coordinating the whole webinar. Thank you so much. Thank you so much, all the delegates, for joining us this evening. Thank you so much.
Thank you.
On behalf of Shield, I thank everybody, especially Dr. Vasundhara, for giving us this opportunity, because we are in the last day of PCOD Awareness Month. But PCOD awareness has to be a continuous one. I thank Dr. Nivedita and Dr. Vasundhara for giving this opportunity for Shield Healthcare. Thank you very much, Doctor.
Thank you. Thank you so much.
Thank you.